Okay, first of all, why do we perform ablation for VT? Of course, we know that ICDs helps us for sudden cardiac death, to prevent sudden cardiac death, but still, when the patients have then ICD shocks, it is associated with a decrease in quality of life, but also then increased mortality due to the shock. So what we do to prevent is, of course, antiarrhythmic drugs is there for long years, and then they affect the refractoriness and conduction properties of the tissues. But what we do with catheter ablation is also to find out the critical substrate and then go specifically for these areas and then do ablation. When we look globally to what VT ablation studies then says, they say us is, so from the beginning, the VT ablation studies showed that ablation of VT is associated with a decrease in ICD shocks in several studies compared with antiarrhythmics or not. But in the recent studies also, we had a decrease in the primary outcomes, including all these, the cardiovascular death and appropriate ICD shocks, VT storms. And the studies demonstrated that clearly ablation is associated with a decrease in the VT recurrence in these patients. And then from the latest study, as an index procedure, when we do ablation in a VT compared to the antiarrhythmics in Venice 2 study, it's also demonstrated that going for ablation in index procedures for VT is associated with a decrease in primary composite outcomes, mainly driven by appropriate ICD shocks and treated sustained VT below the detection rate of the ICDs. So the data is clear. Ablation is associated with less VT recurrences in ischemic cardiomyopathy patients. And when we looked at the differences of ischemic versus non-ischemic patients, of course, the scar distribution is clear compared to the non-ischemic patients. That these are confined to the territories of the coronary artery disease in ischemic VT patients. And the scar type is more compact, more confluent and predictable compared to the wide range of non-ischemic cardiomyopathy. And the ablation targets are from the point of, let's say, the EP grounds. What I mean is the lavas, LPs, and all these substrates is clearer compared to the non-ischemic cardiomyopathy and ischemic cardiomyopathy. So this is why we have better outcomes after ablation in ischemic cardiomyopathy patients compared to the non-ischemic one. So when we look to the mechanisms, of course, this 3T circuit model is the concept for long years that we try to find out in many of the patients while we are doing ischemic VTs. And what we try to find out is, of course, due to the mostly endocardial involvement of these slow conduction regions, we try to find out with high-density catheters the critical isthmus and to map these areas. And then when we find these areas and then go in an effective manner of RF ablation and nowadays with pulse width ablation, we have the chance to terminate the VT. And if we have the chance to map the whole circuit with high density mapping and then ablate during and then terminate during ablation, so this is associated with better VT freedom in clinical studies. But we very well know that activation mapping cannot be performed in many patients because of non-inducibility, because of several factors, the change in autonomic tone, the antiarrhythmic drugs taken, or the general anesthesia in the laboratory, but also the hemodynamic instability is a major concern in most of these patients. And only 1/3 of the patients are hemodynamically stable to be mapped in the laboratories. And then the third is, of course, degeneration into another VT or ventricular fibrillation is another issue while trying to go for activation mapping in these patients. So substrate-based ablation approach gained interest for long years, and then many different methods are evaluated. Of course, in the beginning, voltage maps are much more popular because the voltage maps generally shows you where there is the abnormal substrate. But after we know that having an idea about the late potentials or lavas that are the surrogate markers of slow conducting regions may help us, because if we target these areas, then we can get rid of the VT recurrences. And in the latest years, we have more data regarding the functionality of tissue and its role in the critical isthmus of VTs. And then when we looked at the functional evaluation of VT substrate, this can be done using the isochronal late activation mapping or using the let's say deep mapping techniques. That means that when we pace from the ventricle, look from the fate of the signals of these slow conducting regions. So this is an example of what we have in such a patient. As you see in the middle part of the slide, in the upper part, the late potentials are demonstrated, and the white arrow is demonstrating the isochronal crowding of the colors. That is a marker of slow conduction there during sinus rhythm, or this can be during pacing. And then when we look to the activation map of the same patient, you see that these are in the same area. So these are co-localized. So this is an example of how functional mapping helps us to find out the critical substrate in an extensive substrate patient. And another method is, of course, to go for decrement evoked potential. So we do program stimulation and look to the fate of these signals. And it is nicely demonstrated here. When you look during sinus mapping, you may not see the critical EGMs having role in the VT reentry, but when we do pacing, you have the chance to elucidate, to make these signals visible in these patients. So this is an example of a 69-year-old male patient with ischemic cardiomyopathy with a low ejection fraction. You see the extensive substrate in this patient. So when we look traditionally, what people do in these patients, of course, to go for low voltage area ablation. But as you see here, this is a very extensive area to go for, and you cannot specify the critical area just looking for these voltage maps. So what we do is we go for functional mapping, or look for the critical substrate by evaluating the signals by pacing or during sinus rhythm color propagation. So these are the signals there, and they're accumulated only in some part of this low voltage area. And when we do pacing and look to the decremental properties of these signals, you see that this is in the same area that we had color crowding during sinus rhythm. And you see the fancy signals that are made visible with pacing. And then this is the VT induction, and this is a common scenario in these patients, that we have hemodynamic then instability in these patients. So this is why we have to go for more complex substrate evaluation techniques to find out the critical substrate in these patients, because most of the time we cannot go for activation mapping in such low ejection fraction patients. And then, of course, pace mapping helps us when we have a template, and pace map can show us the critical isthmuses, the parts of the critical isthmuses with the high pace match, of course, with the short sinus. Then a short stem core restoration is compatible with exit sites. And when you see in the right side with a long stem core restoration with a, let's say, higher matching or a abrupt transition, may show you the mid-isthmus side. And when we looked at the correlation of maps of the same patient, you see the color crowding here. In this extensive substrate, we have the chance to specify our areas, and pace map, having the template of the VT, can show us how it propagates. And this is the activation map of the patient in a very short period of time using high-density catheters. Maybe this is the most advantageous part of the using high-density mapping catheters in such patients, because in seconds after determining your area of interest, you can put your catheter to these areas and then do induction of VT, and in maybe 30 seconds, without letting the patient to go for hemodynamic instability, you can get the real, the correct propagation pattern during VT in this patient. Of course, having an idea about the 2D substrate is important, but 2D layer of the VT critical isthmus is important, but it is not the same in every patient, because there are several challenges in catheter ablation. First of all, most of the time we conceptualize the VT critical isthmus as a 2D structure, but this is not so. This is a 3D structure, and this is very well demonstrated in also imaging studies demonstrating the critical corridors of the VTs. And the second thing is, of course, we generally think it as turning around an obstacle or in a figure of 8 manner, but it is not the same in most of the time, especially in case of extensive substrate or in the era of early revascularization. And we know that there may be multiple entrances, multiple exits, many bystander areas that may confuse the operator while doing VT ablation. And one of the important then insights regarding ischemic VT ablation is most of the ischemic VT critical circuits are 3D structures. They are not 2D structures. This is very nicely demonstrated in this recent study. So generally, we try to think that the non-ischemic patients are much more 3D, but really most of the ischemic patients are, as you see here, in the endocardial, there's activation gaps, but in the left-hand side, epicardial map of ischemic VT demonstrates the whole circuit. So we have to think that the ischemic VT patients are mostly 3D than structures. And this data is from our laboratory. And the cardiac MRI detected VT corridors, and specifically for ischemic patients are located not endocardially most of the time. They involve mid-myocardium and also epicardium. And the presence of epicardial substrate is the major determinant of recurrence after successful ablation in these patients endocardially. So we have to think that these the critical circuits, most of the time, as you see here, there is an activation gap in endocardial map. And then when we looked at the reentry in 3D manner, it is 3D structure. And of course, intramural substrate is another important concern in the septal side, and RF, and maybe the pulse field technologies are developing also for VT ablation, for deeper lesion formation, but still it's a challenge for the operator to have deep lesions in the intramural side. So alcohol ablation or some, let's say, needle ablation that I'm going to mention in the upcoming slides may help us. So intramural substrate is really critical. So not always the substrate is subendocardial in ischemic patients, and we have to go for the intramural substrate. And there are some novel EGM annotation methods also to better specify the area of interest with voltage maps. So when we look at the voltage maps in the left-hand side, you see an extensive substrate with the gray areas. And then when we look for isochronal late activation mapping, this refines our area of interest. And the activation map, as seen here, shows us the area is very close and there's a narrow corridor of VT here. And then when we go for the novel EGM annotation algorithms, this peak frequency mapping that's used also in atrium, but also in ventricle, this peak frequency mapping may mark the highest frequency signals in low voltage areas. And then before going activation mapping and trying to do all these issues during hemodynamic instability, then circumstances, you may have an idea about the slow conducting zone. So if the patient has high peak frequency regions in low voltage areas, so this is important for us to target these areas in maybe deep mapping methods. And of course, having an idea of substrate using all these methods, the peak frequency mapping, the deep mapping, the functional mapping issues, then you have an idea where the critical isthmus is. As you see here, most of the time, the patients have hemodynamic instability, and using these high-density maps, you can just put your catheter on and then have these mid-diastolic isthmus, and then you can go for ablation even in this short period of time. So high-density catheters helps us to find out these critical areas in a short period of time. Even the patients have these hemodynamic instabilities. And in the last part of my talk, I would like to touch the issue of the VT ablation approaches. Of course, traditionally, we try to go for substrate homogenization because we know that there's abnormal substrate, and when we get rid of it, we may have a higher chance of VT non-recurrence. But there are different methods also to specify the ablation method in these patients. Of course, when we are able to get rid of late potentials, we very well know that there is less recurrence. And this is the same for SCAR-D channeling. So if you find out the channels, and then go for specifically for these channels, also this associated with less recurrence. But when we looked at the studies shown in VISTA trial, both in endo and epi studies, when you go for endo plus epi ablation and get rid of the substrate, then you are more successful in terms of VT recurrence. But another important concept is, as I showed you, then different examples of the VT substrate. The substrate is very extensive in most of the patients, and then it is not easy to have an efficient ablation in all these areas. So targeting functional substrate instead of giving then non-efficacious ablation lesions to other areas or bystander areas, then gain the interest in the last years. So targeting functional substrate demonstrated good results. And now a facile VT study is on the way by the Rotang and colleagues. And then they are now looking for they are comparing the the substrate ablation strategies compared with the functional ablation strategies. And the functional ablation strategy seems to lessen the procedure times by targeting the real critical isthmus areas. And as I mentioned, there are several concerns about the intramural lesions. So how to go for effectively in these areas. So alcohol ablation is a one solution, or sequential unipolar bipolar ablation, or infusion needle and RF ablation, or maybe in the upcoming years, the pulse field ablation with infusion needle may be a solution. But also there are different, in the era of pulse field, there are different types of pulse field catheters that may put deeper lesions in the intramural sites. And there is also ultra-low cryo energy applied both endocardial and epicardial to have the better intramural effect. And then now, new design pulse field catheters are on the way to put nearly 10 millimeter depth lesions in these areas. And then we very well know that from the pulse field biophysics that the repetition dependency of pulse field ablation, in contrary to RF ablation, so when you do more, you can safely have deeper lesions with pulse fields. So with all these improvements in these ablation technology, I think we will have improvements also in putting better lesions to intramural sites. And in the last part of my slide, I would like to mention that, of course, the mechanism is clear in most of the patients with ischemic cardiomyopathy, and ablation is efficient in the beginning of the disease process. But the process is not, let's say, stopped after one event, and then the patients may have more coronary events or ischemic events by time. And then this may increase the substrate in these patients. So although, of course, the ICDs are important for the prevention of sudden cardiac death, and the ablation then decreases the VT recurrences, but by meantime, patients may need additional ablation methods, as well as they may go for transplantation in very extensive disease, and we may not be effective in the very, let's say, advanced disease forms. So to summarize, the long-term success of ischemic VT ablation is still limited, despite huge improvements in the recent years in decrease in VT recurrence and ICD shocks, and 3D delineation of VT isthmus by imaging methods, MRI, then computerized tomography, but also high-density mapping insights using different EGM acquisition methods may help to understand the exact mechanism of the VT. And functional mapping especially then gained a huge interest in the recent years, may help us to, let's say, to define the substrate better than just looking to the voltage parameters. And randomized control studies, of course, are needed to elucidate the role of optimal timing of VT ablation as an index procedure or recurrence or after ICD shocks, or novel mapping methods to define the critical substrate, like functional mapping methods, their extensive use, and novel ablation methods and strategies like bipolar ablation, but especially in this era, the role of pulse field ablation. So thank you very much for your attention.